So,
Yes.
Very good morning, all of you. Today, in today's fellows teaching session, we'll discuss about femur shaft fractures in children. And we have my dear friend, Dr. Easwer from Kerala to guide us through. And I'll invite Dr. Chinmay and Charlene to, Dr. Chinmay is a consultant pediatric orthopedic surgeon in Amravati, one of our alumni, and they will moderate the session. Please, Chinmay.
Yes, thank you so much, sir. Good morning, everyone. So today we have a topic which was acute fracture shaft, acute femur fracture shaft in children. So today we have an eminent professor, Dr. Easwer, who will be giving a talk on this management. Sir has completed his first fellowship after his MS with Dr. Sriram in Chennai, which was followed by the fellowship in orthoscopy with Dr. David Rajan. Then he interested in doing more pediatric work. So he did his first clinical fellowship at Singapore, which was followed by limb deformity correction at Korea. Subsequently, sir also had an interest in the spine surgery. So he had observation at Germany, and in cerebral palsy, he worked with Dr. Freeman Miller. So he have a vast experience and the clinical experience in the field of pediatric orthopedic. So I will invite sir to give his talk on acute femur fracture in children. Thank you.
Hi, thank you so much for the nice intro. Glad to be here in Orthokids fellow teaching program. So we'll just deal with acute femur fractures in children, and I was asking Dr. Maulin whether to make it didactic or make it practical. So I made a mix of both, so that the younger colleagues can learn a little bit of theory, and then we'll examine various practice scenarios where those theory principles would apply. So this is what we are planning to do, a little bit of theory and then balance it out with a few case scenarios to make it interesting. So the theory first. So about 2%, it makes it about 2% of children's fractures in total. Male children being more active and probably more involved in sports, and possibility of them getting injured in road traffic accidents is more. So maybe there is a skewed gender ratio here. Generally, the cause of the fracture ranges from a very low energy falls, like falls from mother's laps, fall while playing, and then it goes all the way to high energy trauma. So there's an important group that you have to consider. This is the non-accidental trauma. The non-accidental trauma, that's what used to be called as child abuse. It is to be kept in mind when you see a transverse fracture. The fracture pattern also is very important here. You see a transverse fracture, especially in a child who's less than 1 year of age, not able to voice out what actually happened. So in those situations, this is something that you have to keep in mind. And don't forget that it may be pathological also. There may be a bone cyst hiding somewhere, and also in bone weakening conditions, especially in osteogenesis imperfecta, the milder variants where you're not seeing the multiple fractures. This may be the first fracture that you see, so that has to be ruled out. And in high energy trauma, you need to look for these visceral injuries. There may be, even in the femur, there may be a neck of femur and then a femur shaft fracture. So you need to take an X-ray right from the top to the bottom, and need to rule out other internal injuries, head injuries, and multiple fractures you have to look at. And don't forget that the physis, especially the distal femoral physis, can get injured, and this can come back to haunt you after the shaft of femur has healed. So you need to watch out, especially in fractures, to see whether there is any subtle evidence of distal femoral physeal injuries, especially in these high energy traumas. So the radiology, as I said, you need to include both the joints above and below, as in the general dictum in orthopedics, but especially here, because you want to pick up those lesions of skip kind of fractures, either in the proximal or the distal. Also want to check on the physis. So you need to include the knee and the hip in any X-ray. The adult classification has some interesting details on the comminution, and this probably works well when you're trying to plan, especially later on when you're planning to fix the fractures and you're doing an intramedullary nailing. The adult femur fracture classification has these features. Like, for example, in the fracture pattern in type 1, it's less than 25% comminuted. That is of the cortical, the bone width, about 25% is comminuted. When it comes to the second type, it is about 50% comminuted, and this is more than 50% comminuted. There is a large butterfly fragment, as we call it, and then we have the multiple combinations. So this generally can guide some treatment and also helpful in communicating with colleagues. The treatment, as per the book description, goes according to age. The Pavlik harness can be tolerated in any child from, say, newborn to about, say, 6 months. 6 months is stretching it, but about that age. And hip Spika, generally, I apply from anything around even 4 to 5 months also to around 4 years of age, 5 years of age. And again, there is no hard endpoint here. It all depends on the child's body habitus, which is very important. The mother willing to take care of the child in a Spika, and also additional considerations as to, the nursing facilities itself, if the mother is working at home. And closed or open reductions, that is for, of course, an older child. And we have 3 options in that area. We have the IM nail, which is the tense nail, and then the locking plate and external fixator. And also we could potentially use a standard intramedullary locking nail, which we use in adults. So we'll examine these things when we come to the cases. So as a diagnostic matrix, we would practice to interpret it into a table. We can use this table roughly. If a child is less than 6 months of age, regardless of the pattern of the fracture, they should heal well. So all it needs is a Pavlik harness. And a little bit older child, maybe older than, say, 2 months or so, I would prefer a Spika. Any child more than about 5 months, 4 months, going up to about 5 or 6 years even, you could consider Spika if the fracture configuration is stable. In olden days, in this category, that is probably a little bit of gray area now. When the fracture is not length stable, that is, if it is unstable, that is a combination in the mid diaphyseal area, and it is unstable. The older traction, that is the Russell's tractions, was applied till the fracture was so-called sticky, and then you could apply a Spika. And in certain cases, you may not be able to operate immediately, especially the child has other visceral injuries or thoracic or head injuries. In those cases, to quickly stabilize the fracture, external fixator is still a lifesaver. In an older child, more than, say, 6 years to about 14 years, again, if it is length stable, the choice here is pretty much straightforward. The current easy option is TENS or elastic nailing. But if it is length unstable, the TENS doesn't work that well, the principle doesn't work, or very proximal or very distal fractures, then we could think about submuscular DCP, LCDCP, or external fixation. In a much older child, again, these children, if they are very obese, we can think of even a standard IM nail, standard adult locking IM nail. That is probably what would be useful for these children. It's very difficult to maintain these children on TENS nail, so a more rigid device is necessary. So if you're a little bit apprehensive of putting a standard locking IM nail, then you could, and if there is comminution also, then submuscular plating with LCDCP is an option in these children. So this is the general plan. And as you will see with the cases, that this is a very fluid plan, but this is the broad options which are available with us. So there's a couple of points about each of these that you must remember. If you are doing any of these, that is, if in a smaller child, and for whatever reasons you are using the so-called previous generations treatment, like this traction, the Bryant's traction, you must remember, especially since we don't do these regularly now, remember to keep the knees slightly flexed. And this is very important, and you just keep the buttocks slightly off. So this is where the fracture gets reduced, and it's very important for the vascular reasons that you do keep the knees slightly flexed. Now, in a polytrauma situation, there may be a reason to delay the fracture, and these used to be standard in any orthopedic ward, but probably not anymore. But still, if you are opting for one of these to delay the fracture for, say, a week or so, this is the position to apply the split Russell traction with a sling under the calf. So that to relax the femur, and there is a slight knee flexion here. So if you do apply the Spika, there is a position that you have to be aware. You have to remember the 430s. That is, you have to abduct the hip by about 30 degrees. You have to flex it by about 30 to 40 degrees. You have to externally rotate by the same amount, and also flex the knee by the same amount. So why this position is chosen? So that the femur is at the most relaxed positions, especially the muscles which cross two joints, the iliopsoas, the abductors, the hamstrings, and the quadriceps. All these are in the most relaxed position, so that you can reduce the femur and it allows a tension-free reduction. So this is what the key for hip Spika reduction. You have to remember the 430s. If you do opt for tense nailing, then you have to generally remember that it works well for these fracture patterns. There are workarounds, which we will discuss, but generally this is meant for length stable or so-called transverse fractures, or even short oblique fractures. But fundamentally, the fracture has to be non-comminuted. Segmental fractures, TENS is possible, but it is a little tricky. And certain spiral fractures where there is a cortical support, you can use TENS. So have a look at this. This is the general principle of TENS. So in a TENS, what is happening is that you have a distal fixation point, which is the first fixation point, and you have the proximal fixation point where the TENS nail ends, that is the second one. And then you have the elastic effect of it, which is going to press against the cortex on the inside. So these three fixations give it the 3 point, and which stabilize it in any flexion moment, which stabilize it during any translation event. And it also provides some kind of a springing axial security. So it's just like, axial stability is also offered. The rotation stability is not much, but it does offer that. It allows little elastic spring back to happen. So these three fundamental principles have to be met. There has to be a proximal fixation, there has to be a distal fixation, and the maximal width should be at the fracture site, pressing against the inner cortex. And when you bend, there was people used to bend in all sorts of ways, but generally you measure the most narrowest part of the medullary canal, roughly about 3 times of that you can bend it. But sometimes I do insert with minimal bend, especially only at the nail tip, and it just finds its own way. So it's not a hard and fast rule, but it usually comes out nice. And when you choose a size of the nail, you have to make sure that you have to have an equal size of it. If you use unequal size of the nail, it has got some mechanical disadvantages, and also this is generally the measure that you use. You measure the medullary canal width, and you assume that you're going to leave 1/3 of the space free, and the nail is going to occupy the rest 2/3. So you just choose the nail according to that size. So these are the sizes. These nails are available now. Earlier it used to start from 2, and now it's even 1.5 is available, which is useful mainly for children's forearm fractures. So and all the way to 4. And there are end caps available, especially useful for distal femur fractures, where you are opting for TENS, and you can get this additional cortical purchase and security there. So this is in brief, how do you plan for TENS? You leave roughly about 1 inch away from the physis when you're doing a femur. As you insert, you are inserting with the point pointing distally, and then you turn it around as soon as you enter the mid-diaphyseal area, mid-metaphyseal area, and then introduce it up to the fracture site. And if you have the opposite side, you introduce it till then, and then advance one nail and use this nail to reduce the fracture and subsequently introduce the other nail. So this point A, where there is the end point, and as you can see, it is pressing against the cortex, and that is very important to achieve our aim of 3-point fixation. We need to have a point of fixation here. But there are situations, especially in distal femur fractures, where you can't do a retrograde nail. We have to do antegrade. And then when you do antegrade, you don't have the medial option, entry option. So in that case, you need to contour the nail either in a C curve or a very slight S curve. So one nail goes from lateral and then it enters the from lateral to lateral. And the other one goes lateral. And because of the S curve, it takes a bend and goes medial. So this is how you enter. You enter in the subtrochanteric area and in an anterolateral particle position. And then this is the final configuration these nails end up in. So that's enough theory, and we'll see how we can, in case scenarios, how this works out. So this is a child, just about a 4-month-old child, and you can see a fracture. The child fell from mother's lap. This was initially treated by my colleague, and this is just to point out the pitfall of treatment. I mean, most of us would opt for a hip spica here. And so the choice of fracture treatment is pretty obvious, but you can see the way the spica is ending. It is not even the spica. This is some kind of strange long leg plaster which was applied, and the top end is here, which means that, you know, just at the fracture level. So obviously a fracture which was to start with undisplaced has now become displaced and angulated. But this also shows you what kind of tolerance limit you're dealing with in children's fractures, especially a child as young as 4 months. So in spite of all this and the angulation, you can see that the remodeling is starting now, and it is quite well remodeled at the end. So we do have that remodeling potential to play with. So quite often, even if, you know, it is there or thereabouts, it unites. And as I think Professor K. Wilkins used to say, that as long as you put, you know, in a child's bone, both bones in the same limb, it unites. So it's that kind of remodeling potential a child as young as this has. This is a slightly different scenario. I thought of choosing different kinds of scenarios rather than speaking only about the routine traumatic things. So this is a cerebral palsy child who is completely bedridden, GMFCS 5, fully activity daily dependent. And this fracture was sustained when the mother tries to abduct the thighs for a toileting purpose. So obviously the bone is very weak, and you can see some rickety changes in the upper epiphysis here, and it is widened. So this is the position the child is lying in at home, and this is the only position the child can lie in. Any other position is not possible. The child just turns on one side. You can see a large pressure sore of some time ago, which had developed, and then subsequently this posture was adopted. So you can approach it in a traditional way, but I chose to do it in a way that will allow, you can just fix the fracture and deal with it. But here what I have done is I have used the fracture as an opportunity to do a valgus so that there is a slight abduction of the thigh possible, and future such fractures get prevented. So the toileting also in this case becomes easy because you are abducting the distal fragment away. So you can be slightly, creative with these solutions and do the best for the patient. So the fracture can be an opportunity in some situations like this. So this is an older child. This is about a 12-year-old child, but a very obese child. And this child sustained the fracture, slightly distal fracture, and it was associated with a Lisfranc injury to the same side. So again, 12-year-old, our option is a transverse fracture. It is a length stable fracture, and it is slightly distal, but not too distal. So the option here again is pretty straightforward. can go with tense nailing, and you can see this. I have ensured that there is proximal purchase, and these two are actually engaged in the bone, and in fact, this nail is slightly, it's just like this. It is flushed with the outer cortex. And you can see the point of maximal contact is at the fracture site, and there is a distal contact as well. So we have obeyed our principles. There is a 3-point fixation, and it is a transverse fracture, quite well reduced. We could manage to reduce it close to. So there is a little bit of a comminution here, but in spite of that, you can see adequate cortical support is there. Because it is an obese child, a very obese child, TENS choices imply that you are obeying the principles of TENS. If you don't, then with TENS, you could land up in a lot of difficulty, as we will see in another case. So what about this? This is a very proximal fracture. It's kind of a long oblique or a spiral. So this is a 10-year-old boy. And there may be people who may opt out and say that it is length, probably not length stable, and then go for submuscular plating. We still managed to do the TENS, and we introduced a screw here, a percutaneous screw, and you can just see that we've done some temporary reduction measures with shank spin here, but we managed to get a reasonable reduction and a good union. And this is not an ideal solution. Maybe we may be better off with submuscular plating, but this is still possible. So again, a very similar fracture. So we are just trying to see how different this can be managed. Again, a very similar fracture pattern, probably a little bit more proximal extension to this. And this is sustained by a road traffic accident. There's a low energy road traffic accident actually, just fell from a two-wheeler. So again, we use TENS, and you can see the quality of reduction here. So I put this case to illustrate the point that there has to be a proximal purchase. And you can see that we have introduced the TENS nail far up into the neck, and actually in the lateral view, it is actually abutting the cortex. And again, a long purchase, and you can see the cortical, you can hardly make out the fracture line itself. So we managed to get a very good reduction with this, and we opted for TENS. Otherwise, submuscular plating is an option in this as well. But if you have adequate support, cortical support, and there is no comminution, even in a proximal fracture, you can introduce TENS, just pure TENS, close reduction, and get away with it.
So this was an 11 years old, right?
Yeah. 11 years.
Case match.
Okay. Sorry. Yeah. That's a typo. Sorry. Okay. So we can get away with that. So again, another similar fracture. Again, a proximal fracture with extension almost to the subtrochanteric level. And again, it's a low energy fall. So these fracture patterns are sustained in a low energy in a rotary force. So this is a 12-year-old. So this was done by my colleague, and here you can see that it was TENS with an additional circlage. Circlage traditionally is not used in fracture patterns, especially said to inhibit. If you read the older books of internal fixation, circlage is generally frowned on, and then it inhibits the bridging canal. In this situation, this is a good choice because you end up with an adequate cortical support. So this is something that you could consider. Now, another child, 7-year-old with a road traffic accident, a similar fracture, but in this case, you can see that there's a large butterfly fragment. And we have a few options here. Obviously, TENS may not be the option because there is a cortical support which is missing, and TENS may be a bit unstable if you introduce that. Submuscular plating is an option in this age, but we reduced it on table and we felt that the reduction could be achieved with hip Spika. So this is a tool that you have to consider in your armor, that this is an option that you can consider even in a child as old as 7, so that you can see how well it reduced back and it has healed back quite well. So don't just forget the art of Spika. The art of hip Spika is very important. You can reduce close and maintain these fractures if you counsel the mother properly. So again, the family care system is very important. Generally, internal fixation devices require less intensive care, and that is a potential option if you feel that the family is not up to the mark. And there may be social structures which don't allow caring for, say, about 6 weeks in a hip spica. Especially in a female child, the toileting and all that is an issue. So there are considerations, but this is definitely something that you should keep in mind. And this is another child where again this is a mid-shaft fracture. Also, this is not standard fracture. This was sustained by a trivial fall, GMFCS4, cerebral palsy side. But you do notice that the moment you think about TENS, then you notice that there's a huge area here that's probably, rickets. And we are not sure how well the point of nail entry would fix the nail. So again, this was operated by my adult colleague actually who does trauma. So we discussed this, and then at that particular point, we did not have LC-DCP. So he just applied standard DCP. Not the ideal solution, especially you can see the width of the DCP is slightly more than what we would have liked. But this was done without disturbing the fracture site too much, allowed minimal disruption of some tissues. And this is mainly, we felt, because it allowed early mobilization as well. So this is an obese child, the girl child who underwent TENS elsewhere. And you can see that, it is about to fail. So they came to us in this situation, and you can see that it is about 4 months since the fracture was fixed. And you can see that there is some changes of atrophic non-union developing here. And there is a large bridging posterior callus, which the body is trying to heal. But in spite of that, the nail is potentially failing now, and it may break. So one of the reasons why this may have happened is that you can see that this nail is not introduced proximally enough, and both the tips are pointing in the same directions. And the 3-point principle has probably not been adhered to. So we revised this and we introduced a locking compression. Unfortunately, I don't have the X-ray. I just misplaced it somewhere. So sorry about that. But we just did an open reduction. We took out the nail, and we resected this posterior callus, and we did a proper open plating. We achieved fairly good compressions, and we introduced some local bone graft as well. The child is doing well. So this is another scenario that you might see. This is done by my colleague here. And you can see that there is a large fibrous dysplasia. And this child was actually under our follow-up when they sustained this. Again, a low energy fall. So how do you approach this situation? So the child is 15 years of age. And you can see that the trochanteric epiphysis is all fused, and the upper femur, lower femur seems to be okay. So you must remember that there is the adult tool in your armament. So you can use a locking standard rigid fixation device. And also it gives you a large working length and a good rigid fixation, especially in a situation where the entire femur has got various fibrous dysplasia lesions. So it went on to heal unevenly. So this is another child, 11-year-old, done by my colleague here. You can see that it is comminuted. There is a very large lateral cortical displacement here. And obviously, it's very proximal as well. So the cases we saw earlier about the proximal femur, they did not have comminution. They had a stable cortical contact, which allowed us to get away with TENS and a screw to fix, or a TENS and a circulage wire, but that would be difficult here. So the other option we have is a submuscular plating. So the submuscular plating, you can do it in a so-called minimally invasive way. We can introduce it submuscularly. We can afford to stay off the bone and then just fix the two ends and have a large working length in between. These fractures generally do very well. So that's all. I think I've hopefully covered the various scenarios which we have. as far as fracture shaft of femur is concerned. And then we can, I think, now discuss some more cases. Thank you.
Thank you for the presentation. So it's a lovely presentation, and the chart you provided initially according to age wise is excellent for every fellow. So there are some questions which was asked by the participants, like age and physis for intramedullary nail. What for extremely small child with undisplaced fracture? Do the tense nail do the care?
First is for the age. So you did mention in the chart an age limit for the consideration of intramedullary nail versus the tense nail. So locking intramedullary nail. So do you consider only age, or many a times we get children at 14 years of age who have the proximal as well as the distal physis which are open. And with that, the triradiate cartilage is also open. So do we have a look at the physis, or we just consider that this child has reached 14 years of age and now is amenable to unlocking intramedullary nail through the physis?
Yeah, actually, I think it was Dr. Venkat from Ganga who presented on his series of locked intramedullary nails, even in open physis, if I'm not mistaken. So age is not the only criteria, and if it is about to, there is very little growth left, you can take the X-ray of the hand, and if the distal phalanx still has the physis open, that is roughly a guide as to how many years you have growth left. If the phalanx has got the physis open, it means that about 2 years of, more than 2 years of growth is left as a rule of thumb. So then you can decide accordingly whether you want to interfere with the trochanteric apophysis. We can potentially put a smaller nail so that the distal femur physis is taken out of the picture. And that all depends on the fracture configuration also. If the fracture is slightly distal, then you are in a little sticky wicket, and you may want to opt for a submuscular plating because you want a more distal working length. So age is definitely, only not a number that you have to consider other things, especially the amount of growth left if you are interfering with the trochanteric entry nail. So, so that's what. Yeah.
So in recent iFix, we discussed that the GT growth after 10 years is negligible. And now we see adolescents like young adult structures. So Dr. Sheetal mentioned that they have done trochanteric entry nail even in 10 or 11 years old. And that is obese kids, and that is quite doable. And now during this iFix also, we found that few companies have their prototype trochanteric entry nails. For the fractures with fibrous dysplasia or Olier's disease, where the shaft length is less, we have also used either tibial interlock or humerus interlock nails. And that's how it can work. But any trochanteric entry nail can be done, I think, after 10 years, if that fracture morphology asks for. So after 10 years, there won't be any problem with the growth, I feel. Everyone shows one case of growth arrest, which is my case, which I saw someone did Ender's nail from piriformis fossa, and it ended up in a significant coxa valga. But very few people have experience of AVN in the head after, they're using very big nail or significant coxa valga. So after 10 years, and the entry point should be tip of trochanter and not the piriformis. That should be the message. Yeah. Easwer, do you use intramedullary nail along with a temporary X-fix in some length unstable fractures?
For reduction, no. Reduction, we just go ahead and you're talking
yes, some of them are length unstable fracture, and you want to avoid this submuscular plating. We tend to put in monolateral temporary X-fix to
I have not used X-fix in femur, but that's definitely an option. Yes.
Yeah. Next question, Chinmay. Shalin.
Yes, sir. Yes, sir. The next question by Dr. Meet. Can we use a pelvic harness in age at 4 months? The case you shown us in the presentation, sir.
Yeah. See, that's what the pelvic harness is at about 4 months is a bit of stretch. We can use it, but I think 4 months means it's easily can apply a Spika, and Spika should be probably easily maintainable also. I would opt for a Spika at about 4 months of age.
And sir, one more question. How Ender's principle different from tense nailing?
Yeah, fundamentally, Ender is a stacked nail principle where you kind of, I actually was about to put, and I thought it might get very long. So I opted out of putting the Ender's nail. So you just introduce more and more nails inside. So it's stacking, which is working in Ender's nail. It is a cheaper alternative where you're probably working in a low resource setting and everything. Tense nail works on a principle of elastic recoil. So you have to obey those principles, otherwise it will fail. And it is only amenable to certain fracture types because it is using elastic recoil principle. So you need a less combination, you need 3-point fixation. So if you're not able to achieve that, and there is not enough cortical contact, then tense nail is not the implant fit. Ender, since it's just stacking and you're introducing more and more nails and you're filling the canal, it probably works well for even slightly comminuted fractures.
So being in Gujarat and Ahmedabad especially, it's kind of Makkah of Ender's nail. And my professor, my teacher, Dr. Pankaj Divetia, who brought this concept to India. But, early in my practice, we had a lot of CP children with sharp femur fracture with trivial trauma. The father tried to bathe the child and fracture the femur. And then I was wondering, they're usually a long spiral fracture. And then I took help of some adult colleagues, and we used to fix them with a stacked Ender's nails because their hygiene was not good to bear any open surgery or plating. And we used to give a unilateral hip spica. Unilateral hip spica after fixing with Ender's. I was always in fear that it would come out or child will not tolerate. But it's once the fracture gets fixed, the spasms go down, and you can give some muscle relaxant after. And they all did well. So all those fractures in cerebral palsy or very severe rickets, we opted to be away from plating because they all are inherently weak bones. And we had experience of the second fracture will happen at the end of the plate after some time. And then you have to revise the plating. So we kind of prefer intramedullary. And I've seen Enders being used extensively in some part. That's also an option. Yeah.
Yeah. So after putting a tense nail in a child, do you immobilize him in slab or any hip spica, 1.5 spica, something like that?
Sorry, the question was not audible.
Sir, after putting a Ender's nail, after putting a tense nail, for sharp femur fracture, the older children, do you immobilize him in spica or just a slab?
I have not put spica in fact, I have not put spica in any child whom I have done tense nail on. At the most, they get a long leg slap and they stay in bed. Even I have used knee brace in children who are cooperative and the fracture pattern is stable. But it's slightly proximal fracture even, I have gotten away with putting a little higher slab rather than a spica.
Sure, thank you.
Sometimes we see cases. So what do you do for the entry point after inserting the TENS? So do you use end caps? Because sometimes we have seen cases where the entry was, despite the entry being just above the physis, there is physial damage from the entry point and the child goes into either a valgus or a varus after a sharp femur TENS nailing. So I think I saw 1 or 2 cases who were operated outside, which you showed, at TENS coming well below the physis. And we see in some of these cases, they have knee stiffness. And do you bend the TENS nail at the entry point after the final fixation? Because I think I did not see any of the cases you did having a bend at the end. So what do you do at the end after the fracture fixation?
Yeah, especially when you bend the end, it does make it easier to take it out. But if you bend the tip, then it irritates the IT band and all that and gives all sorts of trouble. So I need to kind of leave it flush. My entry is well above. The X-ray might give you a false perception that the entry is probably low because you leave the nail long. but the entry is well away from the physis, and there is no reason you should get a physeal injury if your entry is well above the physis, at least an inch above, about 2 centimeters above at least. I bend the medial one a little bit because there is less irritation there. I feel the lateral one, if you bend and leaves it proud, it irritates the IT band and it causes pain, bursitis, and things. So after I enter, then usually what I do is either bend it with the instrument. I use the suction tip, the metal suction tip, and just bend it a little proud on the medial side. So it makes it a little bit easy for me to take it out on the medial side. The lateral side, I just leave it a little long so that I can always do it, the bending, when I try to do the implant removal and then pull it out. So far, there is, I mean, at least in my series, there is no physeal injuries.
But how frequently you follow these patients? I mean, radiographically?
I'm sorry?
How frequently you follow up this patient radiographically at 3 weeks, 4 weeks? What will be your protocol?
X-rays at 3 weeks typically after the post-operative period, and X-rays at 3 weeks and then at 6 weeks. That's all. Every 3 weeks X-ray till you knew.
Thank you, sir. So I think there is no more questions right now. We can go with the presentations, next presentations. Dr. Shinam.
I think Dr. Meet would present the case first. And then if time is there, then Shinam should present it.
Meet, you can share your screen.
Yes, sir. Is it visible, sir?
Yes.
Okay. Good morning, everyone. So today I'll be presenting a case of shaft femur fracture in a 6.5-year-old boy. So this is a 6.5-year-old boy. He's a resident of USA and son of a senior orthotist who was practicing in Ahmedabad. He had a history of fall from bicycle and present over there with a pain, swelling, and deformity of the left thigh. So this is the X-ray that we had. This is a lateral view. Unfortunately, we do not have the anteroposterior view for the same. So as we can see, this was a closed fracture distal at the distal third level of the shaft of femur.
Yeah, so now actually this patient is in US and the grandson of one of our senior orthotists here. So immediately they sent the X-ray to me that Molinbai, how we should get it treated. And 6.5-year, relatively bit chubby, a complete fracture at this junction of distal. So what, Easwer, what would you suggest if your orthotist grandson has injury in US?
Do you have an AP of this?
I mean, they sent it earlier, but in AP it is fairly kind of stable pattern, not much translated. What is more striking was in lateral view. So AP is more benign than this. So we usually have 4 options, right? Meet, can you go ahead with the next slide?
Yes, yes.
Yeah, so Easwer, just tell us your preference in this situation. 6.5 years old, moderately built.
It is a very chubby child that I would be doing submuscular plating on this. Difficult to maintain in a Spika if it is very chubby, and so probably
still this is doable through an antegrade TENS. Can't we?
Antegrade TENS is another option. Yes.
Or even retrograde. I think there is space to put nails from bottom. Can you go to the X-ray, Meet, please? I mean, we have some place. I have this juncture, and once you see the AP view, you will realize that yes, this can be nailed through retrograde. Yes, Charlene and Chinmay, what would you do this for this? 6.5 years. Yeah.
So 6.5 years with a chubby child, I will go with the antegrade nailing, sir.
Okay. Charlene, what? Yeah, my God. It's a 1C and 1S curve as Easwer mentioned. Charlene, what would you do? Is he here or not?
Yes, the same antegrade nails.
Antegrade nails, okay. Right. So that I suggested either an antigrade or a retrograde TENS. I was pretty sure that I can do retrograde TENS. And then they forwarded this message to the orthopedic surgeon in America. And let's see what he did, what he chose.
So these are the four options that we have. This was a paper published in the IGO 2021, and it gave a age-wise and a fracture pattern and weight-wise protocol for managing a shaft of femur. So the patient is 6.5 years old. So they suggest if the depending on the nature of the fracture, if it's a fairly undisplaced fracture, then even early spica casting or skin traction with delayed spica casting can be considered. If the fracture is stable with a weight of less than 49 kgs, then they suggest TENS nailing. And with a weight of more than 49, as we have discussed in a chubby child, submuscular plating or flexible intramedullary fixation using stainless steel. So this was what was done in the USA, and this is the 1 week follow-up that we have for the same.
So that my orthotist colleague is now very much worried that, sir, we say that if you want to do the nailing, we give full freedom, and the surgeon said, no, I mean, I'm a bit scared of putting nails across an infection and this and that. We can treat this well with a spica. And there is some more angulation, in the lateral view after applying the spica. So Easwer, this is 1 week follow-up now. In AP, you can see it is not much displaced, but in lateral, it is getting more angulated. So how would you approach it now?
Provided I'm continuing with the spica, I would wedge the spica at this point of time so that, correct that angulation. It is a pure angulation, easily wedgeable and correctable.
Yeah. So Meet, show what is the exact angulation. And
so we have an angle of 31.1 degrees at the site.
So at the age of 6.5, what is acceptable? Yeah, Meet.
So how would everyone like to approach it now? Would you like to continue with the same spica, reapply the spica with some correction, remove the spica and pass an intramedullary nail, or would you like to do something else? So coming on to the acceptability criteria for diaphyseal femur fracture.
So before going to that, Dr. Easwer said that he would like to wedge this spica. Chinmay, what would you do?
Yes, sir. I will also think about wedging.
Wedging. Shalin?
Yes, sir.
Sorry, wedging?
Yes, wedging, sir, because 15 degrees, I think the acceptable angulation at more than 6 years of age is almost double. So needs to be corrected. So if we are taking him under anesthesia, wedging again wouldn't happen without it. So if it is well early on, within a week, we can consider TENS nailing to stabilize the fracture which is once displaced already.
The question is also, if we do wedging and if it gets further displaced at 2 weeks, then probably the fracture would start gluing, and we won't have much time there to put a nail. But wedging is definitely an option. Yeah, fine. So Meet, go ahead and show what was performed.
So this is from Rockwood and Wilkins 8th edition, and as we can see here, from the age of 6 to 10 years, the anteroposterior angulation, the acceptable limit is for just 15 degrees. So now this was the 1 week follow-up that I had shown previously, and it has an angulation of 31.1 degrees. So would we accept the angulation or should we do something else? So the surgeon opted for wedging of the cast, and this is what we have now at 1 week after just post the wedging of the cast.
What is the angle? Yeah.
As we can see, the angulation has reduced from 31.1 degrees to 27.5 degrees.
So what I was informed that under wedging, they found substantial correction, but in follow-up again, there is some sagging, and there's 1 week post-wedging, 27.5 degrees. So Ishwar, at 2 weeks after injury, 1 week after wedging, this is the lateral view. Should we accept it or should we do something else?
I mean, this is not acceptable at this age. We have to correct it. So there are two options. Either you can take under child anesthesia, osteoclasis, and a new spica, because I can see that there is quite a lot of gap between the skin and the spica itself. So I assuming the spica has become loose at this point. So a new spica is definitely an option. If it is too sticky and then it doesn't come at 2 weeks, then we can consider antegrade nailing. I would think about antegrade nailing with an osteoclasis.
So at this juncture, you know, they made me talk to that orthopedic surgeon, and it happens so that it is easy to opine when you're on the other side of the table. And I was of the same opinion that this is not going good, and if it goes further, then the child might need some secondary surgery. And he said that one good thing he said is that we should consider the bowing of opposite femur also. So we don't aim at 0 degrees. There is always 15 degree of bowing in the normal femur. And looking at the age of child, I feel that this will remodel. So I don't want to do anything further, and we'll just wait. And the skin contour under the spica doesn't look very bad. So I said that that's right. And so he opted to continue with this spica. And once the radiologic callus is seen, they switch to a walking spica, unilateral walking spica. So that, and I agreed with him looking at this plan. I said, yes, if needed, then we'll do something else in future, but do not, let us not open or put nails at this point. So we had a long discussion, and that's what he was inclined to do rather than putting nails. So let's see what happens next. Yeah, Meet, go ahead.
So this is just a paper about the wedging of the cast, which suggests that the average angle that the average correction that has been obtained ranges from 7 degrees valgus to 2 degrees varus, and from 7 degrees of recurvatum to up to 2 degrees of procurvatum. This was published in the JPO 2018. So now at 3 weeks, the bilateral hip spica was considered to a walking hip spica. So as we can see, the patient ambulates with the spica, and this was a paper published in JBJS 2011 by John Flynn. It suggested that the orthopedic outcomes of the walking hip spica resulted in a lower care burden for the family. And however, there was always the risk of that the wedging adjustment of the cast might be necessary due to fracture malalignment. So this was a 3 weeks follow-up with the walking spica. At 6 weeks, the walking spica was removed. And as we can see, there's a good amount of callus that has formed now. And this is the follow-up we have at 6 months. This was the 1 year follow-up. We can see the thickened callus has now shifted to the diaphyseal area. The anteroposterior alignment seems perfect. And the child is a taekwondo master. He has a black belt in it. And as we can see in the first image, he can bear complete weight on the left limb, and he has no problems, no functional problems at all.
Yeah, so it remodeled well, although the grandfather said there is a small bump when I feel his thighs in the front, but he's strong and he can do all the activities. He's also a swimmer. So this is, I know that the family and the doctor would have gone through a lot of turbulence and challenges and stress points in the treatment, and the outcome is good. But doing a nail at the outset, that might also be an option, and the surgeon and the family would be at ease if the nailing has been done in a right way. But this case suggests that there are extended indication of each treatment. And if a senior guy says that I would treat with plaster, so that is also doable. And the children can have a good sporting life after that. Easwer, your comments on this?
Yeah, it illustrates that, you don't need to always stick to the operative things, but operative things in a modern lifestyle and a demanding parents is also puts everybody at ease if you have a reduction up front, and then you don't have to wait for the remodeling to show to the parents that it does remodel. So
yeah, so I was surprised that the BZ Center in New York, where they are like, they are behind putting nails, and this surgeon was like treating conservatively. So I think, there are surgeons following the principles, what they have learned, in their training, right? So I think we have 5 minutes, and thanks, Meet, for nice presentation and review of literature. I would invite Shinam to take us through Orthokids' practice of this, hip Spika application and the mobile, how we try to smoothen the post-Spika care in children so that it is very readily acceptable to the families. So Shinam, are you there? Would you share your screen?
Yes, sir.
And Shinam will take us through our design of Spika table. She'll take us through our Spika technique and the hip Spika stroller, which we have designed, and we use it for all the patients for shaft femur or DDH. Yeah, Shinam, please go ahead.
Hip Spika table, hip Spika cast, and is oftenly used in traumatic as well as atraumatic conditions. Straight spine and pressure-free abdomen are essential for the child's comfort. With this, the evolution of the hip Spika application device started from a simple stand to a box table to a modern leg holder. The main goal of designing this hip Spika table was to provide a portable device and inexpensive device. This hip Spika table has two parts. We can see here acrylic sheet and metallic base. This metallic base has 3 bars over it and with 3 knobs to accommodate the acrylic sheet. Acrylic sheet has holes to accommodate the knobs over the metallic bars. We can see here the child with head is supported with pillows, and this Spika table can bear weight up to 50 kgs. This is a top view. We can see child is comfortably placed over the hip Spika table. These are the dimensions. We don't need to go into the detail of dimensions.
So this Spika table has a place underneath, and so it is easy to apply the Spika. And secondly, when we remove this acrylic sheet, there is enough space around the tummy so that you don't need to put the window around umbilicus or so. So that will be seen in this Spika application video. Is it playing, Sheena?
Yes, sir. Firstly, this is the table shown here. Firstly, the child is...
Sheena.
Not being shared. You need to share the YouTube screen itself. Right now, you have just shared the PPT screen. So okay. I think you need to share it.
So Shinam, what you need to do is you have to close this presentation and then you have to go to YouTube and play from there, I think.
Yeah, you have to stop share and then share again, selecting the YouTube.
Okay. Or what you can do is, in meanwhile, you can finish this stroller part, and then you finally show this, so that you can show the stroller design if you wish. Yeah, hip Spika stroller. So make it a full screen, please. So Shinam, we are not able to listen to this, so you can take us through.
We devised this device for the safe mobility for the child after hip Spika application. This stroller is simple, affordable, and low profile. The basic frame is made up of 25 into 25. Seating arrangement connects the main frame at 90-degree angle and seat has 25-degree inclination. We can adjust the sitting bars according to the size of the child. These are the actual images of hip Spika stroller from the side and back view. There are 5-point safety harness and adjustable holding bars as shown in the video. This is the extreme 3 years old girl with right side DDH, and we can see the child is mobilizing on the second day.
Yeah, so Easwer, we have been using this stroller on a hospital-based loaner program. So we have around 5-6 such stroller, and all the hip Spika patients take it with them, and they pay some deposit, and once they return it back, we give them money back. But this makes the care very easy. We teach families to how to put this child on the stroller in the hospital. On day 2, they are mobilized. On day 3, patient has been placed and secured by the family itself, so that they can do it confidently once they go home. And we have found very good feedback. Some families, they ask that, sir, can we retain this stroller even after Spika is removed, because they are so comfortable. And the extended use is they put the child on this, and then they finish their potty and the hygiene part. That is very easier than to do when they are up reclined. But the main advantage has been the care burden on family has been less, because they don't need to hold the child, and child spends a lot of time upright rather than being reclined and having issues of back, the ulcerations and perspiration and all, or respiratory infections. So this is a good help, and I suggest all of you to keep 1 or 2 such strollers in your hospital and loan it to the families. This paper was also published in IJO.
Yes.
So we can share these details and designs also if you want to make it. And now our orthotist can courier it to you as well. So the person who is making this stroller. Yeah, Shinam, we have 5 minutes past. So let's quickly go through the hip Spika application technique.
Okay, sir.
Or I think hip Spika, let us stop here. And final comment, Easwer?
Yeah, I think overall, I think it's a very nice session on where we share our experience about femur fractures, a little bit of theory and what we do here and what you do in Ahmedabad. So it's very nice, and especially since you mentioned about how you use Ender's nail, something we've kind of forgotten in cerebral palsy. So I am not even sure whether Ender's nail is available in Kerala anymore. So
yeah, so there are a lot of I can share some, and as you might know that there was a paper from, I think, Texas Scottish, right, and they have compared enders with tens, and they have found them more stable, and they do not undergo bending when you use stacked nails. And they have used it for old children between 40 and 60 kg body weight. So that's now coming up that stainless steel implants are coming up again. I think, thanks Easwer for your time. It was a wonderful session, and a lot of pathological fractures you have shown. So shaft femur fracture is not only these trauma, but it was also pathologic fracture. So I think, yeah, there is one last question by Puneet, and Easwer can answer, and then we'll wind up the session. Shalin, we cannot hear you. Can you be loud?
Yeah. So how do you assess rotations while applying Spika in a femur fracture?
How do you assess rotation? Now, for femur fracture, assuming it's for femur fracture, you have that 30-30 position I talked about, and you have your eye on the patella all the time and the ASIS. So I do it in segments. I do the body segment first, and then connect the body segment to the thigh segment. And as we cover each segment, we make sure that the segments align up. So once you have covered the ASIS, then you don't have the guide of ASIS. So until that is done, you make sure the ASIS is aligned to the patella, center of patella. And once you finish the thigh segment, you ensure that the patella aligns to the second toe. Yeah. So you wait till it sets and then move on to the next. Otherwise, it becomes very clumsy. The person holding the reduction and the person actually putting the spica, the toggle happens if you try to cover the whole stretch in one go. So I do it in segments and then link up the segments.
The other way to look at the cortical width in an X-ray or IITV, that also can guide you that there is not much rotational malalignment. Right, Easwer, thanks very much for that lovely presentation. We'll catch you later again. Thank you very much, all the fellows. Thanks for the hard work. Have a good day.
Thank you.
Thank you.
Bye. Bye, Easwer. Yeah, take care.